This talk is about bar diplopia chart interpretation, especially about diplopia chart findings in patients with left lateral rectus weakness. This talk consists of a brief introduction and the answer to 8 key questions. The main purpose of the introduction is to create a master figure that will often be used in the course of this talk. So let's start. This is the photograph of a patient I saw many years ago. When this photograph was taken, he was looking straight ahead at an object about 1 meter away from his face. As you can see, he had left lateral rectus weakness, which I am illustrating here by a blackened left lateral rectus. In this frame, I have integrated the eye findings to a facial representation. Goggles with the red crystal on the right and the green crystal on the left. The arrows added indicate the turning around of the head. This new position allows us to see the head from the back, and using artistic license I have also drawn the eyes and extraocular muscles as seen through the skull. Notice that the letter L and the letter R have changed side in this frame. Now I have added a bar diplopia chart corresponding to a patient with left lateral rectus weakness. Notice again that in the head figure the eyes are presented in primary position. Nonetheless, the diplopia chart illustrates not only the bar's placement in primary position, but the bar arrangement in all cases. So we have finished the introduction and we will start answering the 8 key questions. The first one is why there is no double vision when looking to the right. This figure depicts the relative force generated by extraocular muscles during dextroelevation, expressed by the frequency of muscle potentials from each muscle. If you do not know what the wiggly lines by the side of each muscle stand for, it is better if you watch the eye movement video on this channel before going any further into this video. Otherwise, let's continue. So, as listed in this frame, during dextroelevation, the left lateral rectus does not contract. During dextroversion, the left lateral rectus does not contract, and during dextrodepression, the left lateral rectus does not contract either. So the answer to this question is because the left lateral rectus is not involved when looking to the right. The second question is why there is double vision when looking midline and to the left. As you can see, during elevation, the left lateral rectus contracts. During primary position, the left lateral rectus contracts. During depression, the left lateral rectus contracts. During levo elevation, the left lateral rectus contracts. During levoversion, the left lateral rectus contracts, and during levodepression, the left lateral rectus also contracts. So the answer to this question is because the left lateral rectus is involved when looking midline and to the left. The next question is why is double vision due to left lateral rectus weakness uncrossed? As you recall, in the master figure I portrayed a patient with left lateral rectus under action with his eyes in primary position, but the bar diplopia chart included the patient's visual bar perception in all positions of gaze. Notice the similar relative position of the green and the red bars in each case and the crystals, represented by the color of the letters. The green bar are to the left of the red bars as the green crystal is to the left of the red crystal. In this frame, I am indicating this arrangement by the white arrows from the letters going towards the bars during elevation. The green bar is on the same side as the green crystal, represented by the green letter L, and the red bar is on the side of the red crystal, represented by the red letter R. That is so during levo elevation, as you can see indicated by the arrows, as well as in all other cases. This bar arrangement is called uncrossed diplopia. To understand the reason for the uncrossed diplopia, we must talk about physiology first and then about pathology. Let's first see what happens in a patient with no diplopia when a bar diplopia chart testing is done. In this frame, I am representing the eyes looking at a white bar at about 1 meter from the face, a distance often used for bar diplopia charting. In a patient with normal eye alignment, the image falls in the fovea, the dead center region of the macula. As the patient is looking through the goggles used for bar diplopia testing with the red crystal on, the right eye will capture the red bar at the fovea, and since the left eye is looking through the green crystal, a green image will fall in the left fovea. I am now representing the anterior segment of the optic nerve fibers corresponding to the area of the fovea imprinted with the images of the bars. Now I am only representing those fibers that from the nasal aspect of the fovea cross at the chiasm, and now I am representing those fibers from the temporal side of the fovea that do not cross. After the chiasm, the left temporal and right nasal fibers join, forming the left optic tract. The fibers from the right temporal and left nasal fibers also join, forming the right optic tract. The optic tracts then reach the corresponding lateral geniculate. From there, the optic radiations originate and travel to reach the calcarine cortex, mostly in the mesial region of the occipital lobe. On the right mesial occipital surface, the visual area extends anteriorly, as illustrated here, but the area for fovea and macular vision is restricted to the tip, areas 1 and 2. And in the left mesial occipital lobe, we have the same story. The primary visual region extends anteriorly, but only areas 3 and 4 are involved in macular vision. So the optic radiations bring the images to the calcarine area in such a way that half of it is presented on one hemisphere and the other half in the other hemisphere, as now shown in the brain illustration. Now the brain does two acts of magic. The first act of magic is to transform the two images into one, and the second to fuse green and red, thus ending up with a single yellow bar at the correct location. So now that the physiological part of the explanation is done, we will move into the pathophysiology side of the explanation. This drawing summarizes the physiology of monoplia. This drawing is so fundamental to our understanding of the explanation to follow that I have placed it on the right side of the frame so we can have it as a reference when building the optic pathways of a patient with left lateral rectus weakness. In this frame, I have added the brain, eyes, white bar, and the representation of the Armstrong goggles, the green and red crystals. Now you can see the nasal and temporal foveal fibers from the normal right eye forming the optic pathway from the fovea macular region to the calcarine area. Hence, when viewing the white bar, the image will traverse the center of the cornea and fall in the fovea, where the red image will be captured, transformed into electricity, and transported to the calcarine cortex, as represented in the cartoonish representation of the brain. The white bar will also be viewed by the affected left eye through the green crystal, but since abduction is faulty and adduction prevails, the image will fall in the nasal retina, outside the fovea macular area, as shown here. I have now represented the optic fibers from the nasal retina, bringing the information to the mesial region of the right hemisphere, as illustrated here and here. Now the brain does its magic as best it can and produces two cortical images, the red one in the correct location, the true image, and the green one, the false image, not in the correct location. So the answer to this question, why is double vision due to left lateral rectus weakness on cross, is because abduction weakness brings about adduction, which displaces the image of the bar towards the nasal retina, and as the result, the false image is on the same side as the affected eye. The fourth question is why top tilts to the left in level elevation. Let's start with a normal patient in level elevation, with the right eye covered. Looking at the left fundus of such a patient, we see the retina, and in it we will see that the fovea is at about the same horizontal plane as the center of the disc. In this frame, I have introduced some anterior eye segments components, the pupil, the iris. Now added the green crystal of the goggle over it, the right eye being covered. If then we present a white bar, the image of the bar will undergo the normal changes created by the cornea and the lens, and the image will land in the retina, exciting cones and yielding a green bar. In this frame, we have eliminated all components except the retina and the bar, and now we have introduced the caricature of the brain we have previously used, and in it superimpose the cortical representation of the left retina and the bar as captured in the retina. Notice the relation of the bar and the foveal disc line in the brain and in the retina is the same. So we have looked at the fundus of a normal patient. Let's now look at the left retina of a patient with left lateral rectus weakness. And here you have it. Notice the relative position of the optic nerve and the macula. The macula is not in the same horizontal plane as the disc because of intorsion. The disc is at a lower plane than the fovea, as you can see in this frame. Now I have introduced the anterior segments of the eye as we did previously in the normal patient, and as we also did in the normal patient, we will place the green crystal in front of the left eye. Remember that the right eye is covered. Now we have placed the white bar in the vision axis. The corneal and lens do their job, and the image of the green bar is captured in the retina in the corresponding retinal area, as you can see. But notice the relation between the fovea disc line and the image of the bar. This bar line composition is transmitted to the brain, where the spatial representation of the retina is normal. That is, the macula optic disc line is in the horizontal plane. So the bar is represented with a spatial specification of the ocular retina, resulting in a bar with the top tilted towards the macula. Now I am bringing back the image of the patient with the left lateral muscle weakness, the arrows indicating a twist that turns the head around. Turning the head around changes the perspective, but as you can see, the bar remains with the top tilted towards the macula, since the change was in perspective, not in position. And thus, during level elevation, bar charting will see the false image of the bar with the top tilting to the left, as illustrated in this frame. Is because intorsion changes the spatial perception of the bar in the retina, and thus the spatial representation of the bar in the cortex. The fifth question is why patients with left lateral rectus weakness intort during level elevation. As we have just seen, during level elevation, patients with left lateral rectus weakness intort the left eye. And the question is why? The answer to this question is convoluted because it requires a significant amount of background information. Let's start by looking at this table. This table was introduced in a prior video. It displays the extraocular muscles and their functions. Notice that the lateral rectus only function is abduction. As you know, tilting is the result of an imbalance between intorting forces that bring the upper pole of the globe towards the nose and extorting forces that brings the upper pole of the globe towards the ears. So it is the sum of these forces, often referred to as torsional forces, exerting their action in the y-axis of the globe, that dictates the degree of torsion. Yet, then why, if the muscles involved in torsion and extorsion are normal, do patients with weak left lateral rectus intort pathologically? In order to ease ourselves into the correct explanation, let us first look at the master figure. In this figure, the eyes of a patient with left lateral rectus weakness are represented in primary position. Were we to ask the imaginary patient to look up and to the left, the position of the eyes will drastically change, as we will see in the next few frames. In the normal side, the right eye will reach the appropriate position in and up, as illustrated by the position of the little white trapezoid on the upper iris, enhanced in this frame for better viewing. The degree of y-axis rotation is appropriate for the eye position. Now let's turn our attention to the left eye. The left eye is up, as it should be, but midline and intorted. The degree of intorsion is indicated by the white trapezoid structure being displaced towards the nose, as highlighted by the arrow. To understand why this is so, we need to remember that during level elevation, the left lateral rectus contracts strongly. As we previously mentioned, the left lateral rectus has only one function, abduction. The superior rectus is also contracting strongly. The superior rectus has three functions: elevation, intorsion, and adduction. The left inferior oblique has mild level of contraction, which produces extorsion, elevation, and abduction. Hence, during level elevation, the y-axis position of the globe is determined by the balance between the superior rectus intorsing force and the inferior oblique extorsing force. Now I will assign a fictitious value to the forces produced by the contraction of these muscles: 4 newtons to the force generated by the lateral rectus, 4 newtons for the force generated by the superior rectus contraction, and 2 newtons for the force generated by the contraction of the inferior oblique. In this frame, I have introduced a simple formula to express the total force generated by the contractions of these muscles. The intorsing force generated by the superior rectus is 4 Newton. The extorsing force generated by the inferior oblique is 2 Newton. The addition of these opposing forces yields 2 newtons of intorsing force. This represents the force necessary to maintain optimal y-axis position during level elevation. Now let's see what happens when the lateral rectus is not functioning. When the left lateral rectus is not functioning, the contraction from this muscle ceases. The absence of the strongest abductor of the left eye leads to medial displacement of the pupil and intorsion, as illustrated in this frame by the shift towards the nose of the shiny spot in the iris. The reason I have introduced the brain in this frame is because the brain is the cause of intorsion. The brain, realizing that the desired position has not been achieved, increases the stimulus to the muscles involved in level elevation, which I have expressed by the up arrow and multiplying by 2. The effect of the increased stimulus is to double the contraction of the superior rectus, as illustrated here by the increasing frequency of the discharges. Thus, the force doubles to 8 Newton. The inferior oblique undergoes similar overstimulation. Its discharge frequency also doubles, so from generating a force of 2 Newton, it goes to generating a force of 4 Newton. I have now added the same formula, but with the new numbers, as you can see. Notice that in normal situations, the final torsional force during level elevation favors intorsion by 2 newtons, and that in patients with left lateral rectus paralysis, the final torsional force during level elevation favors intorsion by 4 newtons. This is a gain of 2 newtons towards intorsion that is reflected in the y-axis position of the eye in these patients. Why patients with left lateral rectus weakness intort during level elevation is because during level elevation, their brain overstimulation of torsional muscles has a higher impact on intorsion than extorsion. The sixth key question is why the false image top tilts to the right in level depression. In this frame, I am bringing back the master image of the patient with the right eye covered and left lateral rectus weakness, but this time he is attempting to look down and out, while the eye is reflexly maintaining normal torsional position. This is achieved in the normal covered eye, but not by the eye with the weak muscle. The eye with the weak muscle goes down midline and extorts. On fundoscopy, since the eye is extorted, the spatial relation between the macula and the disc is faulty. The disc is higher than the macula and not in the same horizontal plane as it should. In this frame, I have added the anterior segment components of the eye and the green crystal. In this situation, a white bar on the field of vision would be captured as a green bar in the retina, as illustrated here. Then the image will be transmitted to the cortex as is, hence the position of the bar will be twisted in the cortical map representation of the retina, as indicated here. The last step we have to follow to understand the bar position in the chart relates to the perspective the chart is plotted. Here, the head is presented face forward. We need to turn it, as illustrated here, to comply with the mode diplopia chart is represented. Notice that in this position, the upper pole of the bar tilts towards the disc nasally. In this frame, I have added the diplopia chart and now drawn yellow lines to highlight the spatial arrangement. So the answer to this question is because extortion changes the spatial perception of the bar in the retina and thus the spatial representation of the bar in the cortex. The seventh question is why patients with left lateral rectus weakness extort during levodepression. The answer to this question follows the same principles used to answer why there is intorsion during levo elevation in patients with left lateral rectus weakness. Hence, I will omit some details already described. This is a representation of muscle actions during levodepression in a normal situation. I have added values for the forces generated by the individual muscle. When the left lateral rectus is non-functional, no force is generated by this muscle, as indicated here. The brain tries to correct the axis of vision by overstimulating the torsional muscles, thus the discharge rate of the inferior rectus and the superior oblique doubles. Doubling the force generated by the inferior rectus and the superior oblique results in an extorting force of 2 newtons more than the required force to maintain normal torsion during levodepression. Thus, in the presence of a paralyzed left lateral rectus during levodepression, the eye is not only displaced to the middle because of the loss of the strong abductor, but also extorted because of the gain in extorting force. So the answer to this question is because during levodepression, the brain overstimulation of torsional muscles has a higher impact on extortion than intorsion. The eighth and last question is why the false images do not tilt in midline gazes or in levo version. This is so because during these positions, brain overstimulation of torsional forces has the same impact on intorting and extorting forces, since unlike in levodepression and levo elevation, they are the same to begin with, as you will see in the following frames corresponding to these gazes: levoversion, elevation, primary position, and depression. Thank you very much for your attention.